Hi, I'm Frank Spear. I want to thank you for joining me. What I'd like to talk to you about in this segment is perhaps one of the most important elements of creating an aesthetically excellent single-tooth anterior implant, and that is the final management of gingival contour. You know, there's a significant difference in what the restorative dentist has to do with gingival contour depending on how the case has progressed up to the phase of restoration. What I mean by that is, typically if we have the opportunity to actually remove the tooth, place an immediate implant, and place some sort of temporary that has an emergence profile built into it, often there's almost no changes that need to be made in the final gingival form, and it's very possible to go to a final impression. But in many cases where a tooth was taken out and implant placement delayed, or for example a congenitally missing tooth where orthodontics opened up a space and now the surgeon placed the implant, covered it back up most likely, performs perhaps some soft tissue augmentation, it's very common for the restorative dentist to get the case back looking like the two examples you see on the screen. The right lateral incisor was an example of a congenitally missing tooth where the orthodontist opened the space up, surgeon placed the implant, let it integrate for a period of 4 to 5 months, and then placed the healing abutment and uncovery, and now it's time for the restorative dentist to correct the gingival contours. The example on the left is a central incisor that had significant bone loss, and so it was an immediate implant, but the surgeon grafted bone and grafted soft tissue and covered the implant up, and so ultimately 6 months after it was placed, the surgeon uncovered it, placed the healing abutment, and now again it's the restorative dentist's turn to correct the final gingival contours. So what I'd like to do in this segment is basically show you 4 different patients and simply show you how they presented to me and then what I did to manage the gingival contours to get to the place that it actually looked the way I wanted it to look in the final result. You can imagine in either of these cases, if you simply take the healing abutment off, make an impression of it with an impression coping on the fixture, and send it to the laboratory, what the laboratory is faced with is way too much tissue. And one of the concerns early on when people started doing single tooth implants was the laboratory was afraid to modify the gingiva. So imagine having too much tissue and the laboratory constructs an abutment that comes to the height of the tissue and then makes a crown that looks like a short little crown because they were afraid to do anything to the tissue. And so it was not uncommon to see single-tooth anterior implant restorations come back that were significantly short-looking because the gingival margin actually needs to be positioned apically. The goal for me in single-tooth implants for the surgeon is always to try and give me way more tissue than I need. Make sure we get papilla height that's good, and I'll create the scallop by moving the tissue facially using the contour of the restoration. The first case we're going to look at is a canine implant. And it is not hard to see when you look at that canine implant that the crown is very, very short. And what happened in this case is exactly what I just mentioned to you. The surgeon did a good job of putting bone there, soft tissue there. The restorative dentist made an impression, sent it to the lab. The lab didn't want to push on the tissue, and so the lab made this little tiny canine crown with this long abutment extending up through the tissue to the head of the fixture. Now, this is an interesting case in that this dentist redid this crown 3 times because the patient didn't like it, but all 3 times the technician made the crown the same length. And so what I'm going to do in this case, just to show you the concept, is I'm actually going to remove this crown and abutment, modify the shape of it so you can physically see how that's going to be done, and then screw the same crown and abutment back in but with a new form so you can watch what happens to the soft tissue. So there's our problem. What we need to do is we need to create tissue contour, and we don't do it typically with surgery. We don't try and do it with a laser or blade. It's the contour of the restoration that creates the tissue contour. So a very simple rule in single tooth implant dentistry is the final gingival contours are very much created by the restorative dentist, not by the surgeon. The surgeon gets us the tissue. Our job is then to mold the tissue. And so here is, in fact, that crown and abutment. And if you look, there's the head of the implant. There's where the gingival margin is. So the reason the crown is way too short is that gingival margin needs to be moved apically several millimeters. Now, how do we do it? We do it by adding contour. And there's a lot of different ways to do this. Most often we do it on a model, and I'm going to show you that a little bit later. In this instance, I actually did it by just adding composite. I aerabrated the restoration here and bonded composite to it. And so here's what it looked like after I completed adding contour to it. So if you now look, there's the head of the fixture, and now that long cylindrical abutment that used to be extending up through tissue is covered significantly by composite. Now, obviously that's what looks like a pretty severe emergence profile. Interestingly enough, in my experience, implants that are a little palatally placed actually do really well in terms of long-term gingival stability. So that emergence profile that is somewhat steep really doesn't bother me. Now, what you need to realize is when I go to put this in, the tissue is in the way. And I'm left with a couple of choices. I can try and cut the tissue out of the way to allow this to seat, or my preference typically is to always make sure when I'm doing any tissue molding that I use a screw retained restoration, and I just slowly tighten the screw down and it seats the restoration. The tissue will start to turn very white. It will start to blanch significantly because basically it's getting a lot of pressure put on it. And once it's to place, I send the patient away. I very, very rarely take any tissue away when I'm tissue molding. I let the pressure of the restoration redistribute the location of the tissue. Now, when you are doing tissue molding, think about how difficult it would be to try it with a cement retained restoration, where you put an abutment in and now you try and push this into the tissue. So that's why almost all of my temporaries are always screw retained, is they allow me to create a contour I want and the screw will seat it to place. Now in this instance, as you can see in these two pictures, there's significant blanching going on around that restoration. So this is the exact same restoration that was there, but with the composite added several millimeters up. And just screwing it to place, it's already raised the gingival margin significantly. Now, somewhere along the line in dentistry, I remember being taught that if blanching doesn't go away in 10 minutes, you have too much pressure and you need to take away contour. I have no idea where that came from, because I can tell you these kinds of cases do phenomenally well. The tissue ends up looking beautiful. So what I do is screw it to place, patients anesthetized obviously, and then send them home. And here's the same patient 4 weeks later, and now that same restoration now has a gingival level that matches the left canine. All of it created by contour, none of it created surgically. And if you want to know how it does long term, here's the final restoration. And the final restoration very much mimics what I did with the composite. And it actually is a screw retained final restoration. But once you've got your tissue molded, it's quite easy to create an abutment with a margin just 1.5 millimeters below tissue and do a cemented crown, because it's easy. There's no pressure in the way then. So here's what it looks like, and these photos are actually 3 years post-restoration of that canine. So that's what that tissue looks like 3 years later. And in reality, nothing was done to this case other than the modification of the contour of the original restoration. So everything that you see in terms of a change between this short one that we started with and the normal length canine came from the contour of the restoration. It's why it's so important for restorative dentists to understand how to manage contour in implant dentistry. You know, it's very different when you're prepping a tooth for a crown, because you have the root of the tooth that's helping to contour tissue. But in implant dentistry, we're totally dependent on contour to create the form of the tissue. Now, to show you a little more detailed steps on how that could be done, and in this segment I'm not going to go through how to make temporary restorations because we cover that in other segments, but I just want to show you this whole concept of how we manage temporary contour to get the tissue we want. So this is interesting in that this is a patient who's unhappy with the appearance of the left lateral incisor implant, and this actually was done by the same surgeon and the same restorative dentist as the canine that you saw previously. And so this patient ended up coming to my office because he had had this crown done more than once and wanted it to look like his right lateral incisor. Well, the obvious problem with it is it's too short. And it's too short because it's the same exact problem. The abutment comes up through the tissue and then the crown form starts. The technician didn't modify contour at all to push the tissue up into place. Now, the first question that you'd want to ask yourself is, how do you know you're going to be able to get that tissue up far enough? And the answer is you better look at a radiograph, because what you want to see is that in fact this implant is apically positioned far enough that you actually will be able to extend contour. Now, typically that's not a problem. Most implants aren't too shallow. But once in a while, one in fact isn't deep enough to allow you to get a normal gingival form. So there's our problem. You look at the gingival levels on the two centrals, they're nice and even. But you look at the gingival levels on the right lateral incisor and on the implant, and there's several millimeters difference between them. The crown length of that left lateral implant is at least 2 millimeters, 2.5 millimeters short of the right lateral. Now, when we take a look, the other interesting thing about this case is obviously the crown didn't get seated completely either, which probably also impacted the fact that we have less movement of tissue apically when we would have liked. And you know, this is a case that had been done using a pre-purchased abutment, I'm assuming. I didn't do the case, but I'm assuming it looks like an old Sarah 1 abutment from Nobel Pharma, which is a parallel abutment. It wasn't tapered. And the trouble with using any kind of a parallel abutment when you're cementing something is if the implant happens to be angled slightly at one tooth or the other, you're not going to be able to get the restoration on top of it. You won't be able to seat it because it's coming from a different angle. And to me, it looks to me like the mesial contact of that crown probably was binding, which is why the crown didn't go completely to place. Now, just as an aside, when you have an unaesthetic existing implant restoration, whenever possible, I like to use the restoration as a temporary. Even though I'm going to make an impression and I'm going to fabricate a new temporary, I'd like to be able to get this restoration off and then put it back in. And in this case, I knew the dentist that had done this, and I knew this is a permanently cemented restoration. So I'm choosing not to cut it off. Instead, I'm going to look at it from the occlusal view and basically try and guess where the screw hole is that's holding that abutment on. And my best guess is, if you really look at it, if we go down right through the center of that cingulum area, we should hit the screw, and in fact I did. So now the advantage is I've got a permanently cemented crown, and I've now got access to the screw hole. If I would have had to go through the incisal edge and the porcelain, I would have done the same thing. I just would have repaired the porcelain with composite when I screwed it back on. So now we unscrew the restoration, take it out, and in fact, not surprising, the tissue is actually very angry because there's been that big gap in there. So I am going to fill that gap in with composite so that when I put it back in, at least the tissue will be a bit happier. So here's what it looked like after I've actually filled in with composite. You can see about 1 millimeter of composite between where the abutment was and where the crown was. That's about how far it didn't seat. Now in this case, I could have in fact added composite like I did in the previous case. But instead what I chose to do is to go ahead and make an impression. And here you can see with my impression coping on that the implant is inclined towards the mesial slightly. So I made my final, well, not my final impression, my impression for an implant temporary. And I'm going to put my laboratory analog on there. And now let's walk through how are we going to determine the contour of the temporary. And as I said, I'm not going to go through all the methods of fabricating the temporaries. I'll just show you on this one case how I chose what shape the temporary should be in order to move the tissue where it belongs. So we've got our impression, and I want to make a pink soft tissue model because it's easy to carve. So the silicone that we use to make our pink soft tissue models sticks to this silicone. So we have to use some kind of separator. And, you know, just to show you the actual process of what it's like to get impressions, this isn't the same patient, but I want you to see how difficult it is sometimes to actually get just down to the head of the implants on these cases where a lot of soft tissue grafting's been done. So you'll notice that I've injected the papilla till they blanch, and now I'm taking the healing abutments off, and I like to inject directly into the papilla and all the way through to the palate, because in my experience the patient's more comfortable than if I just give them an infiltration. And now we seat our impression coping to place, making sure it locks into the hex. And then do the same thing on the other side, injecting directly into the tissue until it turns white, and then continuing to inject until it turns white all the way to the palate. And oftentimes when I get a case back that's been grafted significantly, the tissue may have actually even healed over the healing abutment. And you can either use a scalpel or honestly a laser works great for this. You can't really use an electrosurge because you don't want to hit the implant. But a scalpel just so you can gain access to the screw in the healing abutment, or just take your laser, and if you know where the implant is, just start working your way down in a circle until you can see, just as I did there. And now same thing, we put our impression coping in place, make sure it locks into the hex. Typically I'll now take a radiograph just to assure myself that both impression copings are in fact seated completely, because sometimes they may feel like they're seated and locked in place, but in fact there's a slight gap there because there's still some debris on the head of the implant. And so we want to know everything's in place, and then we go ahead and make our impression. And again, this impression is an impression to make temporaries. Then once we get them place, we want to make sure, depending on if it's a closed type impression coping or an open type one, if it's an open one, obviously you want to try your tray in and make sure that you're going to have access to the screw holes. And then just using polysiloxane and injecting around the impression copings, around the teeth. I want to make sure I inject around all the gingival margin areas because I want to capture the gingival margins very accurately so I can see how to carve the soft tissue when it comes to carving the soft tissue. And then finally seating the impression in the mouth. So that's how the impression's made for the temporaries. We then simply unscrew the screw, obviously, and remove our impression. And I will tell you, using an electric torque driver, an electric handpiece definitely has some advantages for these kinds of cases. Makes it easy instead of having to unscrew all those screws. And now we can simply remove the tray, put our healing abutments back on, and now send the patient away. When they come back, we'll have temporaries made up that we can now insert. And again, this is just one approach to doing it, but it's a nice approach because it gives you time to make a nice model, carve the model the way you want the tissue, and fabricate the temporary on that model. So that when you put the temporary in, it actually will give you the contour, the gingival contour that you're looking for. So that's basically the impressioning process on a case that's had soft tissue augmentation. Again, this is a congenitally missing lateral case, so there was no tooth extraction, there was no immediate implant placement. This was an edentulous ridge that had implants placed and then soft tissue augmented. So now we get back to our lateral incisor patient that we're trying to move the tissue apically, and we have our lab analog in place, and we now want to make our soft tissue portion. And one thing that I usually do is I just take a little green boxing wax and actually just lute it to the silicone so that I can inject the pink silicone gingiva right down around it. But you do have to use some separator, and whatever pink silicone you're using will come with some kind of a separating agent so that the pink doesn't adhere to your impression. So in this case, it was a coltine separator called GI Mask. You spray that onto the abutment and the impression, and then this product was Gingitech, which was then a pink silicone that's injected down into that little boxed in area, making sure you leave the lab analog sticking up so that when you pour stone, the lab analog is locked in stone. And basically, that's how we get our model that we're now going to make our temporary on. So we've got our model, and the first thing I want to do is I now want to adjust the contours on the pink silicone to what I want the contours in the mouth to be. And so I'll simply take usually a black marking pen, and I'll actually start to black out the shape of where I want that gingival margin and what I want the papillus to look like. And then either using a sharp scalpel or a high speed with a diamond, what I do is I carve away the silicone to create the contour I want the gingiva to be. Now, as I do that, what I'll notice is the gingiva is getting very thick. So you can see on the left is after I've carved it, on the right was before. So I've taken 2.5 millimeters away on the gingival margin position. Now when we look down at it, what we can see is that in fact the tissue is very thick. And so imagine that the abutment would come up and then all of a sudden the contour would just go like this. What I'm going to now do is carve inside to create the emergence profile. So I'm going to take away from the inside, leaving about 1 millimeter thickness of gingiva sitting on top of the restoration. And again, you can do it with a sharp blade or with a high-speed diamond. So we carve that away, and now we have our contour for our final gingival form. Now what's going to happen is we're going to put our temporary abutment on, and then typically using some kind of pre-made matrix from a wax-up, we'll just load it with our temporary material and seat it right over the top of this. So without going through all those steps, let's compare the contour of my temporary, which is on the bottom of that right image. Okay? So there's the head of the fixture. Look at the original crown where the contour of the emergence profile is compared to the head of the fixture. Notice where my contour is compared to the head of the fixture. I've extended the contour of the crown a couple millimeters apically. Now, just like in the canine, when I take this to the mouth and I go to seat it, what's going to happen is there's going to be a lot of blanching. But as we talked, that's just fine. So here he is. He's now back, ready for me to remove his crown and put my temporary in. The tissue looks much happier because we closed that gap off by filling composite in there. And here is my temporary seated to place. And you'll notice the blanching. But you'll also notice the gingiva moved apically almost perfectly, almost right immediately. Now, because he had to drive, he was actually lived about 4 hours away from me. I asked if he'd mind just sitting in the office so I could see how long it took for this blanching to go away. And interestingly enough, here's the same exact temporary 30 minutes later. And basically somewhere around 25 or 30 minutes, the blanching was completely gone. Now, usually I'll wait on a case like this. If it looks this good the day you place the temp, I'll only wait maybe 4 weeks and then do a final impression. And so what you see on the left screen now is the same temporary 4 weeks later. And what the tissue has done is followed exactly what I carved into that pink silicone. And so by using the model, identifying ideal gingival contours, carving them into the model, then making the temporary follow the pink silicone, we've now put the temporary in the mouth, and now the gingiva follows the temporary. Now we can remove the temporary, And there's a number of ways to now copy the emergence profile of the temporary, which again we talk about in other segments. But here is basically now the final working model following the final impression that the technician is going to use to create the final restoration. And in this case, it happens to be a gold abutment with a metal ceramic crown on it, because this tissue is actually quite thick and I'm not real worried about anything showing through. In addition, some implant systems don't have zirconia abutments, and in those cases, if you use a gold-colored abutment or if you use a metal ceramic abutment and bake porcelain on it, you can make up for the lack of a zirconia abutment. In designing the whole crown, one of the key facts is now when this gold abutment's made, or whatever abutment you're using for your cemented crown, it's important that your technician keeps the margin of it about 1.5 millimeters subgingival, not much more, so you can easily clean all the cement up. But you can again compare my final restoration on the bottom with the previous final restoration on the top. Now, just as an aside, when I do seed abutments on implants, I actually add a little ointment that's actually a corticosteroid and tetracycline. It's called Easy Seat. And I just put a little drip of that. It's not a thread locker at all. It's actually an antibiotic and a steroid. Cuts inflammation down and kills bacteria. Just a little bit of it will then get expressed along the implant at the head of the fixture. So here it is being put to place. And then we cement our crown, depending on if we're going to cement it permanently or temporarily. First, we torque the implant down, or the abutment, to 35 newtons. And then here's the crown being cemented. And because the marginal position's only 1 millimeter, 1.5 millimeters subgingival, it's very easy to clean the cement up. And this is actually the day of cementation. You can see the tissue looks very happy because the temporary had shaped it, and we really didn't have to do anything to it the day we seeded the final, except put the abutment in place and then cement our crown and clean cement off. So that's the gist of how we position gingiva and contour gingiva around a single tooth implant. It's really quite simple when you think about it. And here you can see we've also done some composite restorations on the incisal edges of both centrals to make them more attractive and more even. But if you look now, the crown length of the two lateral incisors is essentially equal. And when we also compare the smile, you can see the improvement with the composites on the centrals and just the incisal edge form of the new left lateral incisor. So those are two examples of using molding to move tissue. Now, the one question I do get asked is, how long do you wait after putting a temporary in before you make a final impression? And the other question I get asked is, do you ever do surgery? Do you ever go ahead and modify the tissue instead of just waiting for contour to do it? So the last two cases I want to show you actually illustrate that. So we're going to take a patient. It actually is the one you saw the video of making the impression earlier. We're going to take this patient who's had lateral incisor implants placed and connective tissue grafts over the top of them. And the tissue is not very happy because she's been wearing an Essex retainer that actually was digging into the tissue. So here she is with her Essex retainer and the two teeth inside the Essex retainer. But when the Essex retainer was made, the person that made it didn't trim it up short from the gingiva. And so it's actually digging into the connective tissue grafts over both lateral incisor implants. When you take the Essex retainer off, you can see the tissue's pretty angry. There's also a lot of tissue there. And so I did the impression, which you saw earlier, where I injected anesthetic into the tissue, took the abutments off. And now we've got temporaries made just like you saw on a model where the tissue was carved. So what I'm going to show you now is the actual video of inserting the temporaries. And this is the same patient that you saw the video on of making the impressions for the temporaries. And what I do is I inject again right into the papilla until it blanches all the way facial to lingual. And in my experience, placing single tooth implant temporaries can be quite uncomfortable for a patient because there's so much compression of tissue. So I pretty much always blanch the tissue like this before I seat the single tooth temporary. Now we remove our healing abutments, just like we did when we were making the impression. And now we're putting in our screw retained temporaries. There's a little bit of that easy seat on the base of it. Again, antibacterial with the tetracycline and the corticosteroid. And I am simply screwing it all the way to place. And as I am, obviously there's a significant amount of pressure, torquing the temporary down, and I typically torque my temporaries down around 20 newtons. So using an electric torque driver in this case. And we torque both sides down, and then I'm not going to do anything to these temporaries or to this tissue other than just let her go home. I'll check the occlusion, obviously. I'll fill in the screw access holes with some composite, but I'm not going to do anything to modify the form of the tissue. I'm going to see how it responds to the temporary contour. The worst case would be that we actually carve away tissue that we wished we hadn't carved away. So there's no harm in waiting and seeing what actually happens just from contour. So when I fill in the screw access holes, I just typically throw a little cotton pellets in there so that I know the screw isn't going to get filled with composite, and then go ahead and using a body and enamel colored composite, and these temporaries happen to be made out of composite onto an opaque temporary abutment. And now we'll go ahead and one hint about closing off screw access holes is if you want them to look good, if you have an opacious dentin composite, which is what I'm using right now, that opacious dentin composite I put in the screw access hole and on the lingual, so I can then veneer it on the facial with some dentin or enamel. But the opacious dentin blocks the light passing through, and it keeps it from getting that gray, because otherwise these both would show a nice gray circle where the screw access hole is. So by using the opacious composite to fill the access hole, I'm going to get basically invisible finish of the composite that's filling that hole. And then go through your routine disking, finishing, polishing. These happen to be, a lot of it just with 3M discs. And the final polishing, the same thing. However you happen to work with your composite system. And now we've got both of them. The screw access holes are filled, and we're just doing our final polish with the finest of the discs. And then you can also use some of the nice rubber polishing aids that are available today. There's a lot of decent ones on the market. And there's our two single tooth implant temporaries the day they're seated. So this is what it looks like clinically. The tissue doesn't look good. You certainly wouldn't want to be making a final impression today because you have no idea where this tissue is going to end up. So the question becomes, how long do I have to wait? And so I'm going to take you on a little journey. I'd had her come back periodically just to evaluate how the tissue changed with time. The good news is there's no more Essex retainer digging in, so everything should recover nicely. It's just a matter of how long will it take. So that's the way it looks close up the day they were seated. Okay. Here's what it looks like at 14 days, and it's already a significant improvement. Here's the other side, day it was seated, 14 days. This particular patient actually had to leave town for some school issues, and so I didn't see her after 14 days, but at 4 months when she came back, the tissue really looks very, very nice. And at 4 months, I would now choose to do my final impression, make my final crowns exactly like we did in the other patient. And here's what she actually looks like completed with the final restorations in place. And so just an illustration of how, again, we create the contour and then we just wait and let the body adapt to that contour. Now, are there times that you actually might need to do a gingivectomy on an implant? And the answer is yes. Because there are some grafts that are simply so thick that your temporary contour just doesn't make the tissue behave the way you want, and you need to actually do some surgery. So let me show you this last patient that will illustrate that. Missing lateral incisor in a patient with a very high lip line. So we want the gingival to be as ideal as possible. We go through all the steps I've just got done showing you. So here she was pre-treatment. She lost the lateral traumatically. Dave Matthews was the surgeon. He placed the fixture and he did a connective tissue graft. I'm not going to go through all the steps in the process, but he did a beautiful job of overbuilding the tissue. So when I saw her back, she now has the implant, she has a healing abutment, and she has a lot of gingiva. My goal is now going to be just what we got done doing on all those other patients. Make an impression, make a model, carve the tissue, make a temporary, put it in place. She's been wearing a flipper that's been shortened significantly up off this tissue, and so we have a lot of excess tissue. So I now, in the right screen, I have placed the temporary, and you can see all the blanching. So what I typically will do in a case like this is I'm not going to trim anything yet, but I am going to bring her back in about 4 weeks and take a look at what's happening here. Because at the moment, there's a lot of thick, bulky tissue over the top of that temporary. And that's just a close-up for you of the day it was seated. And ideally, because the bone on the distal of the central is actually pretty good, we know that papilla is going to plump up a little bit higher, because if we have bone on the distal of the central, we're going to get a decent papilla on the distal of that central eventually. Here it is at about 4 to 6 weeks. And at about 4 to 6 weeks, the interproximal is looking pretty good, but the scallop of it is still quite flat. And if we compare it to the other lateral has a very nice, pretty scallop. And so in this case, rather than sit and play with the temporary contour, because I really like the contour of this temporary, there's just so much connective tissue graft sitting on top of it that I don't know that it's going to change shape. So I'm going to go in and perform a gingivectomy. And now you can see in this photo, comparing the scallop of the right lateral, the natural tooth, with what I did, and you can use scalpel, electrosurge, laser, whatever you prefer, to trim the excess tissue to match the right lateral, and then also to plasty it, to thin it out some. But I wouldn't do this the day I seated the temporary typically. I would go at least 4 to 6 weeks to see what the tissue does around the temporary before I would actually start carving on the tissue. Now, once this is done, I would go another month of healing, then make your final impression, and then everything else proceeds the same as we talked. And you can see the left screen is where she started, and the right screen is what the final restoration looks like the day it was seated. The tissue profile really very closely mimicking the tissue profile of her natural right lateral incisor. So yes, there are times that I do gingivectomies on implants, but it's almost always a case that's had a connective tissue graft that really thickened the tissue up, and my temporary contour simply isn't adequate to change the shape of the tissue. And you can see with her high lip line, it's really important we got the contour of the gingiva around that left lateral implant to match that natural right lateral. So as I said, to me this section is a critical section for people doing single tooth anterior implants. We have to know how to manage contour so that the contour dictates the form of the tissue. And I hope this has all made sense to you. I hope the 4 cases illustrated what I was talking about. My message would be, don't be fearful about putting pressure on tissue, because in fact when you have too much tissue, that's how you're going to mold it to the correct shape. So it's been my pleasure sharing this with you, and I look forward to seeing you again soon.